See if they have not joined and then.
Okay.
Yeah.
Okay. Okay, so the first thing that we'll go through is hypertension. So hypertension, we know that normal values range, your BP should be below 120/80. Then when you want to diagnose somebody with hypertension, you have to like 2 or more elevated readings for at least two visits. That's how you diagnose hypertension. So if it's pre-hypertension is between 120 to 139 for the systolic and 80 to 89 for diastolic. If it's stage 1, 140 to 159 over 90 to 99, and stage 2, which is more than 160 over 100. So epidemiology, we know it's mostly due to age, and mostly it's the men that get this. But if it's over the age of 64, then there's a higher percentage of women that have high BP than men. So they're like I'll just use this. So when you want your body has this regulation system to, if you have high blood pressure, it has all these mechanisms to lower your blood pressure or vice versa. So when your baroreceptors are inhibited, which are on the aorta, I think, it reduces the impulses to the brain, and this is now to increase blood pressure. And we know that sympathetic system is the one that increases your blood pressure and not the parasympathetic. So it reduces your parasympathetic and increases your sympathetic activity. So some of the mechanisms that it does this, and some of the effects, is that it increases your heart rate and your contractility of the heart, causes vasoconstriction, and it also releases epinephrine and norepinephrine. Norepinephrine and epinephrine bind to the cells of the heart, and now they increase heart rate. And all this together increases your blood pressure. So you have another system, which is the RAS system, which is the RAS system where renin is produced or secreted, and then it converts. There's that whole process of angiotensin 1 and angiotensin 2, which now work on your blood vessels to cause vasoconstriction, or it also works in your kidney, yeah. And what it also does, that aldosterone is also released, which decreases sodium and chloride excretion. So we know that if more sodium and chloride is reabsorbed in the distal tubule because of the aldosterone, then even water will move into your blood vessels because of the osmotic effect. This increases your blood volume, which therefore increases your blood pressure. Yeah. This I've said all this. So yeah, this is basically an overview of what I've just said, where renin converts angiotensin to angiotensin 1, then the converting enzyme to angiotensin 2. Angiotensin 2 has many effects that you can see over here. On the adrenal cortex, which increases aldosterone synthesis, and which there is more sodium and water reabsorption. On the CNS, it increases the or stimulates the secretion of vasopressin, which increases blood volume. Then it also increases your total peripheral resistance and increases cardiac output and vasoconstriction. So all of this together increase your blood pressure. So when you want to regulate your blood pressure, there's this different receptors like the alpha 2 receptors now, which exert a negative inhibition because of when norepinephrine binds to this alpha 2 receptors, it exerts a negative inhibition. But and when they bind to beta receptors, it stimulates. So now beta receptors have like this cause vasoconstriction. And also with the postsynaptic alpha 1 receptors causing vasoconstriction. Yeah, so the beta 1 receptors are in the heart, which now increase heart rate and contractility when epinephrine binds to it or norepinephrine. And now the beta 2, which are in your blood vessels, which have a different effect causing vasodilation. And another thing with the blood pressure, increased blood pressure, is if you have a deficiency in nitric oxide, which in a normal circumstance, when nitric oxide binds to your blood vessels, it causes vasodilation. But with a deficiency, it will cause there won't be that aspect of vasodilation. So hypertension, the causes or the etiology, the primary ones are basically like genetics or heredity, but now for secondary, it's now associated with other diseases such as tumor in the adrenal medulla, tumor in the adrenal medulla, increased glucocorticoid, the Cushing syndrome and chronic kidney disease, and also primary aldosteronism, where now there's overproduction of aldosterone. And of course, with so many drugs, so there's so many drugs that cause hypertension, amphetamines. You can just see there's just many. So pathophysiology is what I just explained before. Just a minute. So when you want to the mean arterial pressure, or MAP, is the average of the pressure throughout a cardiac cycle of contraction. So for this, 2/3 of this MAP is spent in diastole and 1/3 is spent in systole. So to calculate MAP, this is the formula. Then the aspect of cardiac output and total peripheral resistance. So cardiac output is a major determinant for the systolic blood pressure, while total peripheral resistance is an aspect of diastolic blood pressure. And then like I said, they need to be an average of 2 or more readings to diagnose hypertension. So for clinical manifestations or complications of hypertension, it can lead to brain stroke or ischemic attack, retinopathy, On the heart, it causes hypertrophic because now your heart is working more to pump that blood. On the kidney, chronic kidney disease, because when there's high blood pressure, it increases it. There's more pressure on the uh, glomerulus, which now increases. Now there'll be like more filtration, especially like with now your these albumin and other proteins which are not supposed to be filtered. So that also affects your kidney, and over time it can lead to chronic kidney disease. Yeah. For diagnosis, again, you just have to measure your blood pressure, and then the other ones that you can measure or test for is now your fasting lipid panel. So for all this, it's basically to see what else is causing hypertension or what else it has caused. So your fasting lipid panels, your your glucose levels, and your hemoglobin A1, HbA1c. Also, because it damages your kidney, you can see, you can test for serum creatinine level and your albumin to creatinine ratio. Okay, so now we start the main thing. Any questions till now?
No questions, Doc. But now for management, I believe these people, they've managed hypertension. They can tell us.
Yes. Anybody can take us through or whatever they know for the management for hypertension, and then once we discuss, I can just do like a rough review.
There are some diuretics that are given whereby they help in reducing the volume of, whereby when they reduce the volume, like the blood pressure goes down. Someone can chip in on that.
Yes, diuretics is they're actually the first line in hypertension. Any other?
For blacks,
Is it the loop diuretics?
The blacks, I think the first line, you always use the calcium channel blockers plus a thiazide. I think that's the first line.
Yeah. So for, like Safina said, there's loop diuretics, there's also carbonic anhydrase inhibitors, and also the thiazides. So there are different situations where you use these diuretics.
We also have the non-pharmacological modalities such as DASH diet, sodium
Yes.
restriction, also lifestyle changes, exercise, weight loss.
Jai, you can tell us something about the DASH diet.
I think the DASH diet mainly comprises a diet that's high in the veggies, fruits, low fat, yeah, and also
And also low salt.
sodium diet.
Yes. Any other drugs or any other non-pharmacological modalities? Okay then. So non-pharmacological like or lifestyle modifications where you have to of course the weight loss, the DASH diet, which Chai talked about, reduced salt intake, physical activity, and moderation in alcohol intake. So this is the algorithm that is used. So in stage 1, mostly it's monotherapy, either with the ACE inhibitors, the ARBs, or the thiazides. But if that's not working, then you can try the two drug combination with either ACE ARB plus a calcium channel blocker or a thiazide. But in stage 2 hypertension, you have to use a 2-drug combination. And ACE inhibitors are the mainstay, like they're one of the first choice or first line drugs. Yeah, so over here you can see it's diuretics, beta blockers, ACE inhibitors or ARBs, calcium channel blockers, and then now second choice drugs, which are mostly used with combinations. It's alpha-1 sympatholytics, alpha-2 sympathomimetics, and direct vasodilators. So the first one is the diuretics. So I'll just go over here. So some of the drugs that you can use is like acetazolamide, which is a carbonic anhydrase inhibitor and mostly works in the proximal convoluted tubule. The other ones are this loop diuretics, and mostly I think it's furosemide that's used. One thing about the loop diuretics is they're used when when the creatine levels are quite high. So you reserve them when you see that if the creatine levels are high, then you use this loop diuretics. Mostly it's the furosemide, also known as Lasix. Then you have the thiazides, like hydrochlorothiazide, which work on the distal convoluted tubules. And you have the K-sparing drugs like spironolactone or eplerenone. So these these various drugs, like they have their own like disadvantages or the adverse effects. Like acetazolamide can cause acidosis, or it can cause hypokalemia, renal stone formation. Then when you go to the thiazides, mostly it causes hypokalemia, hyponatremia, and one more thing about this, that it causes hyperglycemia. And where is that? Here. So you try to avoid this in diabetic patients, but I think for diabetic patients, mostly it's the loop diuretics that are given. So yeah, then you even have this thiazide-like analogs, and mostly it's the metolazone that's mostly used. Then you have the loop diuretics, and it causes the same adverse effects. It's just an a different ADR is it causes this ototoxicity, especially when it's used with aminoglycoside antibiotics. And for the thiazides and the loop diuretics, they both cause hyperuricemia. And of course, all of them cause hypotension. Then you have this potassium sparing diuretics, and you use spironolactone. But one thing about the spironolactone is that it's not given in Addison's disease. Why? Because spironolactone it antagonizes the aldosterone receptors. And in Addison's disease, we know that there is already less aldosterone. So if you're giving spironolactone, you're making that aldosterone less already, and it worsens the effects, or it worsens the symptoms of Addison's disease. So in case the patient has Addison's disease, you give it's not here. You give something called the eplerenone. No, sorry, you give these ones, sorry. Triamterene and amiloride, which are okay to give when the patient has Addison's disease. One thing about spironolactone, it causes gynecomastia and menstrual irregularities in females. So in such a case, you give now the eplerenone. So just an overview about the diuretics. You have the carbonic anhydrase inhibitors like acetazolamide. You have the thiazide hydrochlorothiazide, which causes hyperglycemia, hyponatremia, hypokalemia, and hyperuricemia. You have the loop diuretics, mostly Lasix is used, and it causes ototoxicity, hyperuricemia, hypokalemia, and hyponatremia. For the potassium-sparing diuretics, you have spironolactone, but it is not used in Addison's disease. If the patient has Addison's disease, you give these drugs, triamterene and amiloride. In case the patient is taking gynecomastia and they have this, if they're taking spironolactone and the adverse effect they get is gynecomastia in males and menstrual irregularities in females, then you opt for eplerenone. So that's for the diuretics. Then you have the beta blockers. So you have the non-selective and the cardioselective. But they're both effective in reducing blood pressure. So the advantages of cardioselective over non-selective is that you can use them in asthma, diabetes, and peripheral vascular disease. So some of the drugs that you can use is for if it's like you want to go for a cardioselective, then it's atenolol, bisoprolol, metoprolol. Then the non-selective is propanolol, and mostly it's the propanolol is the most lipophilic, and atenolol is the least lipophilic. Then some of the adverse effects is that it causes bradycardia, because we know this acts on the heart muscles to reduce heart rate and and it causes bronchospasm. So, and then one more thing about these beta blockers is that you can't just give, you can't just stop, like abrupt. Can you guys hear me? My network is a bit unstable.
Yes.
Yeah.
Okay. Oh yeah, so you can't just stop these beta blockers. You have to taper off the dose over 2 to 3 weeks. The next one are these ACE inhibitors. And what ACE inhibitors do is that they they block or they inhibit angiotensin converting enzymes. So there is no conversion of angiotensin 1 to angiotensin 2. And one more thing about ACE inhibitors is that they increase bradykinin. So you see that's one of the adverse effect is dry cough. So if ACE inhibitors are not tolerated by the patient, then you opt for ARBs such as losartan, telmisartan, valsartan. What these ones do is that they directly block the receptor of angiotensin and not the enzyme. So since there is no bradykinin released or produced more, then you do not see dry cough. But the ADRs are same, except they don't have dry cough. So some of the ADRs that you see is rash, fever, hyperkalemia is one of the common ones, and also, okay, for the ACE inhibitors is the angioedema because of the bradykinin. But you usually start with ACE inhibitors, and then you see if the patient is tolerating them well or not. If not, then you switch to the angiotensin receptor blockers. Okay, yeah. Then other drugs are the direct renin inhibitors, like this aliskiren, which now it blocks or it inhibits the renin. Yeah, so direct renin inhibitor, so it blocks that RAS pathway. So there is no formation of angiotensin 1 or angiotensin 2. So it basically lowers your BP. And this drug is not used in it's not used in combination with ACE inhibitors or ARBs, because they have similar adverse effects. And also this drug is not given in pregnancy because of its teratogenic effect. The last one for the first choice is the calcium channel blockers, which are in two categories: dihydropyrimidines and non-dihydropyrimidines. Yeah, pyridine, sorry. Yeah, so amlodipine and nifedipine are the most commonly seen in the market. Then you also have diltiazem and verapamil. So mechanism of action, I think we'll see all this when we do pharmacology. Yeah, so diltiazem has the calcium channel blockers don't dilate the veins. They mostly affect your cardiac muscles and your vascular smooth muscle cells. And then yeah, and one more thing is when the patient has chronic heart failure or AV block, then verapamil should be avoided because of its negative inotropic effects or tropic effects. Okay, so a review of the first choice drugs. You have, we said, the diuretics, acetazolamide, thiazides like hydrochlorothiazide, loop diuretics like furosemide, case sparing like spironolactone. Second set of drugs is the beta blockers, where you want to use now the cardioselective beta blockers like atenolol, but even propranolol is used. It's just that it's non-selective. So if the patient has like asthma, then you don't give this propranolol because it will worsen the effects of asthma. So you opt for a cardioselective. For beta blockers, when you want to stop the drug, then you taper it off. You taper off the dose over 2 to 3 weeks. The third set of drugs are the ACE inhibitors like captopril and enalapril. They just block the conversion of angiotensin 1 to angiotensin 2 by inhibiting the enzyme angiotensinogen and converting enzyme. ACE inhibitors, one of the common side effects is that they increase bradykinin, so you'll see dry cough or angioedema. In such a case, then you opt for ARBs such as losartan, valsartan, which now directly inhibit the angiotensin inhibitor receptors. And also for these two drugs, you do not give them in pregnancy. They are contraindicated in pregnancy, and both of them cause hyperkalemia. So you do not give them with like K-sparing, like you don't give them with like spironolactone in combination with spironolactone. Then you have the direct renin inhibitors like aliskiren, which can also cause is teratogenic and causes angioedema and hyperkalemia. So they're avoided. So you don't give them with ACE inhibitors or ARBs. And the last ones are calcium channel blockers like amlodipine, diltiazem. Yeah. Then for second line now, it's the alpha adrenoceptor blocking agents. For non-selective, again over here, that blocks alpha-1 and alpha-2 is phentolamine and phenoxybenzamide. With selective, you have prazosin and terazosin. I think prazosin is the one that's mostly used. What these drugs do is that they relax both the arterial and vena and the venous smooth muscles. Yeah, and then the ADRs mostly because like they're alpha adrenoceptor blockers, they can cause like tachycardia. Then you have the second ones, which is centrally acting sympathetic inhibitors like clonidine and methyl dopa, which decrease sympathetic outflow, therefore they decrease blood pressure. For clonidine, it's not like there's a withdrawal effect where the patient can get rebound hypertension. And the last set of drugs is the vasodilators like hydralazine or minodix. What these do is they relax vascular smooth muscle, which reduces the resistance and total peripheral resistance and the blood pressure. One thing about these vasodilators like hydralazine, they can be used in pregnancy. Okay, so an overview for the second line, the first set of drugs was alpha adrenoreceptors, non-selective like phenoxybenzamine, and alpha-1, selective alpha-1 is the prazosin, and they relax both the arterial and venous smooth muscle, therefore they decrease blood pressure. Second is centrally acting sympathetic inhibitors like clonidine and methyl dopa, where they decrease sympathetic outflow, therefore they decrease blood pressure. And vasodilators like hydralazine and minodix, which now relaxes vascular smooth muscle, therefore decreasing blood pressure. With the second line drugs, they usually are used in combination with the first line. They're not used as monotherapy, except for hydralazine, which is used in pregnancy-induced hypertension. So that is it for hypertension itself. Then, so over here, yeah. So in certain situations, for example, if the patient has heart failure, then your treatment choice would be using an ACE inhibitor, ARB, plus a beta blocker, plus a diuretic, plus a spironolactone. So over here, you can just see like what to use in diabetes, CKD, post myocardial infarction. You just see all these treatment choices. Then over here, we can see that the beta 1 selective blockers are safer in patients with COPD, asthma, diabetes, and peripheral vascular disease. You don't want to give non-selective like propanolol for patients that have these diseases because it can exacerbate the symptoms of those diseases. Yeah, any questions? Then we move on to hypertensive crisis. Yeah, and then like a simple algorithm is that you start with one drug, and then if blood pressure is still high, then you titrate that to the maximum dose, or then you add a second drug. That's the first strategy. Second strategy is that you start one drug, then you add a second drug before achieving a maximum dose of the first. The third strategy would be you begin with 2 drugs at the same time, and this is mostly when it's stage 2 hypertension. Yeah, and yeah. Any question, clarification, and then otherwise we move to hypertensive crisis. Okay, can anyone tell me what is hypertensive crisis?
It's like when the BP goes extremely high, like immediately, suddenly, acutely.
Yes. Anything else?
I think it's when
hypertensive crisis.
okay. It's when we have a greater blood pressure than 120 mg. Like when we have a diastolic blood pressure that's greater than 120. That's when we can say the patient is in hypertensive crisis.
Yeah.
And
Anybody?
and in this crisis, we tend to avoid it because it can lead to end organ damage. It can progressively lead to an end organ damage.
Yes. Anybody else?
Maybe a little addition on the same, like when you talk of hypertension, crisis is the elevated blood pressure of above 180 over 120. And as the previous person has said, that it can either lead to emergency, it can be an hypertensive emergency or urgency. Remember, when we talk of hypertension emergency, that crisis will lead to end organ damage. But for the urgency, it does not lead to a target organ damage.
Yes, yes. So hypertensive crisis is divided into hypertension emergency, where there is elevated BP of 180 over 120, and it leads it with end organ damage, while hypertension urgency, the same, but then it does not have end organ damage. So for hypertension urgency, you just have to increase the doses of the current medication that the patient is taking, or you can add additional agents that are rapid acting, like captopril, clonidine, labetalol, and they're usually given as IV therapy. And in hypertension urgency, nifedipine is not given because it can worsen cardiac ischemia. Yeah, so some of these drugs, you either increase the doses of the current medications of the patient, or whatever they're having, you add on captopril, clonidine, labetalol. Yeah. Then hypertension emergency, again over here you're using IV, and some of the drugs that you can use over here is sodium nitroprusside, labetalol, esmolol. There are just many drugs you can use. It's just that you have to give, like, it's more of a emergency because there is now target organ damage. So there's so many drugs that you can use, but all of them are used as IV. Nitroglycerin, enalapril, hydralazine. Yeah. And then one more thing with hypertensive crisis is that you can't lower the BP very low. Otherwise, the patient can go through acute ischemic stroke, where because of the low BP, there is no enough perfusion pressure for the brain or the cell. So you have to maintain at least a bit of high BP of 160, at least to read 160 over 100, so that the patient does not go acute ischemic stroke, because you need a bit of high BP to for cerebral perfusion. Yeah, that is it for hypertensive crisis. Hypertensive crisis divided into hypertensive emergency, where there is high BP of 180 over 120 with acute target organ damage. And there's so many other drugs. There's so many drugs that you can give, especially now the fast-acting drugs like labetalol, esmolol, nitroglycerin, and all of these are given as IV drugs. Then the second one is hypertensive urgency, where BP is over 180 over 120 without target organ damage. Over here, you increase the doses of the current medications of the patients, or you add a fast-acting drug like clonidine, labetalol, or captopril. In hypertensive urgency, nifedipine is not given because it can increase the risk of cardiac ischemia. Again, IV therapy is given. And for hypertensive crisis, BP is not lowered completely, at least 120 over 100. So to maintain cerebral perfusion pressure to prevent acute ischemic stroke. Yeah. Next one is for pregnancy. Anybody? What is hypertension in pregnancy called? Hypertension.
Preeclampsia.
Yes. So you have preeclampsia and eclampsia. Preeclampsia is elevated BP. So yeah, elevated BP of 140/90 after 20 weeks of gestation with proteinuria. That is preeclampsia. Eclampsia now is all those things in preeclampsia, but with seizures. So the pathophysiology is just that there is like a systemic vasospasm which decreases perfusion to all organ systems, and sometimes that there's less oxygen going into these organs. They can be like an inflammatory response or inappropriate endothelial activation, which also leads to activation of the coagulation cascade and formation of the microthrombi in organs that have compromised blood flow. Risk factors is that nulliparity, where this is you've never given birth, the mother has diabetes, renal disease, chronic hypertension, a history of preeclampsia, family history, and an advanced maternal age of more than 35 years. Some of the symptoms is visual disturbances, severe headache, upper abdominal pain, and one more thing that's different is that they usually present with the HELP syndrome, where there is hemolysis, elevated liver enzymes, and low platelet count. So preeclampsia is associated with the HELP syndrome, which is hemolysis, elevated liver enzymes, and low platelet count. Diagnosis is the same, where you measure blood pressure, you see if there's proteinuria, which now means that there is preeclampsia or eclampsia. And of course, the other diagnostic criteria like thrombocytopenia to see if there is this HELP syndrome, liver enzymes, renal insufficiency. Management of preeclampsia is delivery. That's like the definitive treatment. If the mother has preeclampsia, delivery, but in case that you can't, delivery is not possible, then IV labetalol or hydralazine are the first choice. Then to prevent and control the seizures is magnesium. You give magnesium sulfate. Yeah, so preeclampsia, like the most effective is delivery, but in case that you can't deliver, then you give IV labetalol or hydralazine. To control and prevent seizures, you give magnesium sulfate. Then gestational hypertension is now a new onset of hypertension arising after 20 weeks of gestation. But over here, it doesn't have proteinuria or thrombocytopenia and all those things that were in preeclampsia. This is just hypertension after 20 weeks of gestation. And now chronic hypertension in pregnancy is before 20 weeks of gestation. And first line over here is to give labetalol, nifedipine, and methyl-dopa. For children and adolescents, it's usually ACE inhibitors, ARBs, beta blockers, calcium channel blockers, and thiazides, they're all okay to be given for children. I'm sure it's just with lower doses. And for older people, it's the diuretics and the ACE inhibitors. So that is it for hypertension. Any questions? Any questions, guys?
Thanks, Iral. I don't have a question, but a little addition on and hypertensives. You have to note that ACIs and ARBs are contraindicated in pregnancy because they are teratogenic. And in case of preeclampsia, whereby you're giving magnesium sulfate to combat the conversions, and then you get the magnesium sulfate toxicity, we can give an antidote of calcium gluconate. Thank you.
Yes. ACE inhibitors and ARBs, including the direct renin inhibitors like what is it called? Aliskiren, are all teratogenic, so they're not given in pregnancy. So someone has said I talk more about preeclampsia. Okay, so preeclampsia is basically elevated blood pressure of 140/90 after 20 weeks of gestation with proteinuria. That is preeclampsia. Eclampsia is just a complication of preeclampsia, but now it has seizures. Some of the risk factors for preeclampsia is that the mother has previous history of hypertension. No, sorry, history of preeclampsia, diabetes, any renal disease, chronic hypertension, and also nulliparity, which is now never given birth. And clinical presentations with preeclampsia, the mothers usually present with the HELP syndrome, which is hemolysis, increased liver enzyme, and decreased platelet count. So when you're diagnosing this, the mother, it has to, of course, you measure the BP, you see if there is proteinuria, thrombocytopenia, your liver function tests to see. Then the management for preeclampsia is mostly, the most effective is delivery. But in case that delivery is not possible, then you give IV labetalol and hydralazine. And to prevent and to control the seizures, you give magnesium sulfate. Yeah, that's it for preeclampsia. Any other questions or... Okay, so someone can tell me the first line choices for hypertension, please.
Okay, the first line choices are diuretics like carbonic anhydrase inhibitors. Example is acetazolamide, and then thiazide-like diuretics, that's hydrochlorothiazide. Then loop diuretics, that's furosemide. And then potassium sparing diuretics, like spironolactone. And then there's also ACE inhibitors, like lisinopril, and then there's ARBs. ACE inhibitors have bradykinin effect. That's if the patient cannot tolerate, you can change it to ARBs, which directly inhibit the receptor of angiotensin 2. That's losartan, telmisartan, and then we also said beta blockers. They are in the first line. There's non-selective and the cardioselective. The cardioselective was atenolol, and then cardioselective is effective for those patients who have asthma, diabetes. Yeah, those are the first. And then we also mentioned the one that was directly inhibiting the renin inhibitor. Yeah.
Aliskiren.
Huh?
It's called aliskiren. Aliskiren.
Yeah, the aliskiren. And then the calcium channel blockers, amlodipine. Yeah, those are the agents we mentioned.
Yeah, that's good. Anybody for second line choices?
Also, for the second line choices, there's alpha adrenergic receptor blockers, and the one that's the centrally acting one, like clonidine and methyl dopa, and vasodilators. The alpha adrenergic blockers, they are non-selective and selective. Selective is prazosin. Non-selective was phenoxybenzamine. And then this one, we said they directly relax both the arterial and the smooth muscles, so they decrease the peripheral vascular resistance, and that's how they lower the blood pressure. Yeah, and then some of the ADRs will be tachycardia. Yeah, and then we said clonidine has the rebound hypertensive ADR. Yeah. And vasodilators like hydralazine is effective in pregnancy-induced hypertension. Yeah, that's it.
Yeah, that's good. And mostly the second line choices are used in common with and they're not chosen as
breaking.
monotherapy. Yeah, I think that's it for hypertension. We can 20. Oh, sorry. I think we take a break and then we can heart failure. Guys, let's please be interactive.
Yes, please. Yes, please. Let's be interactive. Patrick Waweru.
It's when the heart is not able to pump efficiently.
Yeah. What else?
It's when also the heart cannot meet the metabolic needs of the body.
Yes.
Yeah.
I will also add its inability of the ventricles to fill or eject blood. So it's like a result of structural cardiac dysfunction.
Yeah. Types of heart failure.
Right-sided, left-sided, heart failure with reduced ejection fraction, and the one with preserved.
Yes. Anything else that you guys can add on? Any like the etiology or just in which kind of population it's common in, or the epidemiology?
For etiology, like 60 to 70% of heart failure is related to ischemia. And the most common causes of heart failure is coronary artery disease, also hypertension, dilated cardiomyopathy, and non-ischemic etiologies can be hypertension, thyroid disease, viral illnesses, and pregnancy.
Yes. So I'll start off by explaining what both of them are, and then we'll move on to treatment. You guys can see my screen?
Yeah.
Yes.
Okay. So the first one, left-sided heart failure. So like Fatma said, that heart failure as an overall is it's a disorder of the cardiac muscle that it impairs the ability of the ventricle to fill or eject blood. So like Gaia said, there's the heart cannot meet its metabolic demands. So that is high output heart failure, where there's high metabolic demands, and then there's low output heart failure where there is less cardiac output. Then there is also acute decompensation heart failure, where there is new onset of heart failure symptoms. So the first one, left-sided heart failure. So over here in left-sided heart failure, there is reduced ejection. So that is a systolic failure. So there is no contraction of the ventricles to eject blood to the aorta. Then you have the preserved ejection fraction, which is now the diastolic failure. So the ventricles cannot relax or fill properly. Normal ejection fraction. Anybody who knows the normal ejection fraction?
I think it's usually somewhere 60%, 55 to 60%, not so sure.
Yeah, the normal ejection fraction is 50 to 70%, but in case of heart failure, it's even lower than 40%. So in left-sided heart failure, we know that the left side is the one that pumps blood to the rest of the body, the oxygenated blood. But now that that left side is not working properly, the blood like clogs up or backs up to your lungs. So the venous return from the lungs, and there is like pulmonary congestion and pressure. So that lung that's supposed to be ejected from the left ventricle into the aorta, and to the whole body, it now backs up into the lungs. So because it's left-sided heart failure, you see pulmonary symptoms. You'll see increased pulmonary venous pressure. You'll see pulmonary edema because now there is that all that blood is just going to the lungs, is not going out into your to your body. So you see pulmonary edema. Then because of this edema, there is no gaseous exchange, because now it's filled with water. So now these alveoli cannot, there's no exchange of oxygen and carbon dioxide. So breathing gets difficult. Then pulmonary congestion, which is now just pulmonary congestion, basically. So so with left-sided heart failure, you see pulmonary symptoms like pulmonary congestion, pulmonary edema, breathing difficulties, which causes dyspnea, orthopnea, and paroxysmal nocturnal dyspnea, which is I think even when you're lying down, I think it's that one. Does anybody know what paroxysmal nocturnal dyspnea is?
Yeah, I think it's that when you're lying down, there's that shortness of breath. So if you have heart failure, you need for your lungs to be, or rather your upper body to be a bit elevated. So even in hospital, you see their beds, they are a bit elevated. Because if
Yes,
they lie flat, there's a lot of shortness of breath.
exactly. Yeah, so now we know that now the blood is not going to your other body organs. So you see now supply to this other organs is low, like your blood flow to other organs is low. So one of the major organs that is affected is the brain, causing encephalopathy. So there's hypoxic ischemic encephalopathy, one of the main ones. So failure leads to low organ perfusion and hypoxia. So all your organs are not getting enough oxygen to do their work, leading to hypoxia. Hypoxia now leads to damage to those organs, because hypoxia, I think it increases free radicals in your body because there's no oxygen. Also causes lactic acidosis and all the other things that lead with hypoxia. At the end of the day, it's damage to your body organs, as well as pulmonary symptoms, because all that blood is just staying in your lungs, causing edema, increasing pressure, breathing difficulties. One more thing over here, you'll see a pink frothy sputum. That is one of the clinical manifestations of left-sided heart failure. So just anybody can tell me which kind of drugs can cause this heart failure?
Pardon, Hira?
Which drugs can like exacerbate heart failure or can cause heart failure?
Or something like doxorubicin.
Yes, definitely.
We also have
antiarrhythmics like quinidine, procainamide,
Yes.
and then non-dihydropyrimidines, calcium channel blockers, diltiazem and verapamil, and also the NSAID celecoxib.
Yeah. So these drugs, they exacerbate heart failure is because these drugs they have a negative inotropic effect. When we say inotropic effect, it's that it affects the contraction of your heart. So if it's negative inotropic effect, it decreases the contraction of the heart. All these drugs that you guys have mentioned, antiarrhythmics, beta blockers, calcium channel blockers, other drugs that can cause are antifungals like itraconazole, terbinafine, also cardiotoxic drugs and NSAIDs like dianaceid, NSAIDs, yeah. So that is for left-sided heart failure. Any questions for left-sided heart failure? Okay, then someone tell me what is left-sided heart failure and what it causes. Anyone? Patrick, Serafina, Sonia, Brenda, Faiza, come on, you guys.
Okay, from what you've explained, left-sided heart failure is when the left side of your ventricles is unable to remove the deoxygenated blood. It's supposed to be taken to the lungs. So if there's a systemic failure, the deoxygenated blood will not be moved as much as it should be. So then it leads to the accumulation of the fluids in the lungs, and that can cause edema, and then it can cause the nocturnal dyspnea, which means so guys have said you need to elevate the beds of the people who are suffering from that disease. And then it can also lead to hypoxia, which means parts of the body are not getting the oxygen as it's supposed to be. And then we talked about the drugs that can cause it. There's beta blockers, there's antifungals, there's what else? Doxorubicin. Yeah. That's a summary of what I've got.
Yes. Anybody else? Okay.
You said these drugs, the overall effect of all these drugs is they have a negative ionotropic effect, so they reduce the contractility of the heart. Yeah, leading to all the things Sarafina said. Yeah, that's it.
Yes. Okay, so let's move on to right-sided heart failure, then we can move on to treatment. Anybody else with any questions for left-sided? Any clarification, any question? Okay. So right-sided heart failure is caused by left-sided heart failure. Since your left side is not pumping blood to the rest of the body, there is like less blood to the, okay, no, let me not say it like that. Yeah, but one of the main causes of right-sided heart failure is because of left-sided heart failure. And what happens is that blood backs up in your veins. So all this deoxygenated blood is just backing up in your organs because this right-sided is not pumping blood to your lungs for oxygenation. So this leads to like venous congestion of your body organs. So there are many symptoms now that are associated with right-sided heart failure. In left-sided, we saw that it's mostly pulmonary symptoms, but over here, it's with this other organs. So one of the main things that we see is that increased jugular vein. Jugular vein is what? JVP. What is it called? What's JVP, you guys?
Jugular venous pressure. Pulse.
Yes.
Pulse. Sorry.
Well, yes, that one. Yeah, so because of peripheral congestion, all this blood is backing up into your other organs, causing JVP. Then, because all this is deoxygenated, you're not giving enough oxygen to your other organs. Another organ that is affected is your liver, causing hepatomegaly, then renal failure, peripheral edema, because all this blood is just backing up. You have peripheral edema, weight gain because of this, pitting edema. Then you have ascites, which is just a fluid accumulation in your abdomen. Then you have it also increase one of the main symptoms with this is core pulmonary, where because there is a chronic lung disease, it causes right-sided heart failure. So that is one of the like I said, that right-sided heart failure is caused by left-sided, but one of the other causes is that when there is chronic lung disease, it causes right-sided heart failure. And yeah, those are the main symptoms of right-sided heart failure. All this blood is backing up with that is deoxygenated. Your organs need oxygenated blood, but they're not getting it, causing this damage to all these organs. Yeah, any questions for right-sided heart failure? Okay, what is right-sided heart failure?
So right-sided heart failure, it's mostly caused by the left-sided heart failure and sometimes also caused by chronic lung disease. It's when blood backs up in the veins of the body because the right side is not pumping blood well to the lungs for oxygenation. Symptoms would be increased jugular venous pressure, edema of the liver, renal failure, and also the peripheral edema as well.
Yes. Anybody else? Okay, what is preload? Preload and afterload. When we talk about preload and afterload, what do you mean by that?
Preload is a measure of ventricular filling pressure.
Okay.
As in, it's like the volume of the blood in the ventricles. Like it determines the venous return. And then the afterload will be the resistance to ventricular ejaculation.
Yes. So for heart failure, what we see for preload and afterload is that both of them are increased. I think I had a picture. Let me look for it. Yeah, this one. So preload is just the volume of blood that that comes into your ventricles, or the filling of the ventricles. That's your preload. And afterload is what is the ventricular ejection. That's afterload. So preload, like over here, we can see it is increased in heart failure. And also afterload is increased. So when there is increase in preload and afterload, your cardiac output decreases, but your lungs need to do more work to eject that blood into circulation or into to the lungs. So your heart is doing a lot more work than it has to, and this increases, like now your leads to cardiac hypertrophy or remodeling of your heart. Yeah, that's like one of the pathophysiology aspects of heart failure, that preload and afterload are both increased, which increases the workload of your cardiac muscles, leading to cardiac hypertrophy and remodeling of your heart cells. Yeah, so I think we can go on to diagnosis and treatment. Yeah. Okay, since we know the pathophysiology and what happens in heart failure, what kind of drugs are we using to treat heart failure?
Digoxin.
What does that do? How
Yeah.
does it help in heart failure?
Janet says it boosts calcium. That's a lie.
Yeah, it does.
Okay, and then?
It increases the contractility. It acts as a cardiotonic. Yeah, so that it increases the ejection fraction and all that. Because heart failure is basically when the muscles are weak, kind of stiff, cannot pump well. So it increases that contractility.
Yeah, and then which other drugs?
We will also use diuretics for symptom relief, like decreasing edema.
Yes. Any other? Okay, just a random question. Why do loop diuretics and these thiazides cause hyponatremia and hypokalemia? Just look at the mechanism of action of these drugs and why would they cause hyponatremia and hypokalemia? Anyone? Okay. I'll give you guys time to think about that, then we'll come back to that. Okay, so heart failure is classified into 4 functional classes, where the first class is that the patients have this cardiac disease, but it does not, like when they're doing like any physical activity, it does not cause like this apnea or palpitation. Then class 2, it causes slight symptoms of this fatigue and dyspnea, palpitation. Class 3 is marked limitations, and class 4, which is the worst, which even at rest, they have all these symptoms of discomfort. So this is with the New York Heart Association classification, and this is for the other one, which is kind of the same, where stage A is patients at high risk for developing heart failure. Stage B, where there's structural changes to the heart, like structural heart disease, but they don't have any signs or symptoms. Stage C, they have the disease and they have some symptoms. And stage D is refractory heart failure. So treatment strategies. So we, in the previous, where in hypertension, we talked about all these ACE inhibitors and beta blockers. So I'm just going to go into the algorithm. Okay, yeah, non-pharmacological intervention, of course, dietary modifications with low sodium and fluid restriction, because we know it's causing edema, so you don't want more fluid into your body. Of course, stop smoking, immunizations, because if your body is already weak with your immune system, so there's high risk of infections, especially in left-sided heart failure, where there's pulmonary edema. Then losing weight and avoiding alcohol, and of course patient education on these modifications. Okay, so stage 1, I think there's a, let me see. Yeah. Okay. So stage A, where we say that there is high risk of high risk of heart failure. So the drugs that you use is usually ACE inhibitors or ARBs. What ACE inhibitors do is that it reduces that cardiac remodeling and cardiac hypertrophy. We said cardiac remodeling and cardiac hypertrophy is caused because your heart is working more than usual. So that's like a compensation mechanism of your body. So ACE inhibitors or ARBs, they inhibit this remodeling and hypertrophy. So you use that these drugs for stage A. Stage B, again, you're using ACE inhibitors or ARB, but you can also add beta blockers, especially the cardioselective beta blockers like carvedilol, bisoprolol, metoprolol. And these do this, they have many functions, like it's advantage to use beta blockers because they slow ventricular remodeling. It even slows down your heart rate and inhibits renin release. We don't want renin to be produced because you already have edema. You don't want more reabsorption of your sodium and water. So that's a good thing. And it improves your left ventricular systolic function. So beta blockers are usually given when the patients are like clinically stable and they're volemic. Then when you go to stage C, where the patients now have all these symptoms, some of the drugs that you're giving is diuretics for the edema, ACE inhibitors to reduce that blood pressure, also beta blockers. And over here now you're using this digoxin for selected patients, aldosterone, and of course some devices like biventricular pacing or implantable defibrillators. So what this aldosterone antagonist do, like spironolactone, is again they inhibit ventricular remodeling, and they also attenuate cardiac fibrosis. For digoxin, it inhibits your sympathetic nervous system and increases your parasympathetic nervous system. So sympathetic nervous system, you want it to decrease so that your heart rate and contraction, all that is reduced, and increases parasympathetic. So it just lowers your blood pressure, contraction of the heart, because you don't want your heart to work a lot. Then digoxin is also given to patients who have arterial fibrillation. Then when you come to stage D, where the patients, even at rest, they have all their symptoms, mostly it's like you need like heart transplant or end of life care. Then any other drugs that you guys think would be helpful besides the drugs that I've said right here, which other drugs would be very important in giving in heart failure?
Antiplatelets and anticoagulants.
Yes.
Because the heart is already failed and the risk of thromboembolic effects.
Exactly. So anticoagulants and antiplatelets like aspirin or warfarin are given. So like I explained, your heart or your ventricles are not able to eject that blood, all of that blood out into the system or into circulation or to the lungs. So there's that blood that is left in the ventricles. That's blood stasis. Blood just stays in that ventricles. When blood is not flowing, it causes this clots. So that is one of the complications of heart failure. So to avoid this clots, or even if the patient already has this clots, you give anticoagulants and antiplatelets like aspirin, especially like it's mostly low dose aspirin. One more question. Is aspirin given in asthma patients with asthma?
No.
Why? What is one of the risk factors of asthma? Why is it not given?
It can cause bronchoconstriction.
Yeah, so a type of asthma is the aspirin-induced asthma. So you know if the patient is asthmatic, then you don't give aspirin, you opt for like warfarin or any other anticoagulants, or like which other anticoagulants besides aspirin and warfarin? Which ones do we know of?
Clopidogrel.
Sorry?
The clopidogrel.
Yes, clopidogrel, or you have the unfractionated heparin, or this low molecular weight heparins. Yeah, that is it for heart failure. Any questions? Oh, for diagnosis, you're just looking at the signs and symptoms, and one mainstay, like a gold standard that you do, is the echocardiogram, which is used to quantify the ejection fraction. So ejection fraction is normally a normal one is between 50 to 70%, but in cases of heart failure, it's lower than 40%. Okay, I think we can continue from here in the afternoon, because it's already 12. We'll start with ischemic heart disease in the afternoon at 5.
Hiral, can I add something little on the management of heart failure?
Yes.
Yes. There's a new drug, not new here per se, but they are called neprilysin inhibitors or blockers, such as sacubitril, something. I'm not so certain of the name, but what they do is they inhibit the breakdown of anterior natriuretic peptide. And remember what we said, that in A and P, they will enable us to lose a lot of sodium and at the same time losing water. So we'll be reducing the work of the heart. So it can also be used to make the heart not overwork by inhibiting the breakdown of the peptides, especially the A and P. Thank you.
Yes, I'd forgotten about that. It's the neprilysin inhibitors like sacubitril, and neprilysin is they're usually given with ARBs like valsartan.
Did you also mention aldosterone antagonists?
Yeah, I talked about aldosterone antagonist of like spironolactone, which now attenuate cardiac fibrosis and also inhibit ventricular remodeling.
Oh, and then you also asked why this loop diuretics cause hypokalemia and hyponatremia.
Mm-hmm.
So I think it's because these diuretics, they have effects on the loop diuretics. They inhibit sodium potassium 2 chloride carrier. So they promote elimination of potassium into the urine, if they promote more elimination of potassium into the urine, the plasma level of potassium will decrease. That's why they cause hypokalemia and hyponatremia.
Yes. Yeah, that's actually the cause of hypokalemia and hyponatremia.
I still have a challenge. I know we're using the beta blockers in management of heart failure, but looking at already having the heart failing, and what you usually know is the beta blockers they reduce the contractility factor of the heart, and you're still using. How are they managing the heart failure, or they at the same time reduce the inotropic effect of the heart? I know they are used, but I don't comprehend how.
So, for these beta blockers, we know that it causes this this dilation or whatever, but for heart failure, they have other advantages, like they slow the ventricular remodeling. They also, in some way, they inhibit the renin release. We want renin not to be released because we know that renin leads to angiotensin 2, which now increases reabsorption of water and sodium. But we don't want that because there's already a high blood volume or edema. Yeah. It has other effects, yeah.
Just to add on that, Daktari, we didn't look deeply into the pathophysiology of heart failure, but the chemicals that are the culprits that lead to heart failure are such as angiotensin 2, aldosterone, and norepinephrine. So that's why ARBs will be there, ACE inhibitors will be there, aldosterone blockers will be there, and also the beta blockers, because the norepinephrine, the aldosterone, and the angiotensin 2, they lead to that cardiac reformation, leading to the cardiomyopathy that we see in heart failure.
Yes.
Thanks a lot. Thank you.
Yeah, and this beta blockers, we usually start with low doses of them, and we titrate to avoid the sympathomimetic worsening of already what Gaz was mentioning, because they have a negative inotropic effect. Since already norepinephrine is affecting and contributing to the heart failure, when you're going to give beta blocker to the patient, you're not supposed to start a dose that's already higher. The negative inotropic effect will still worsen the heart failure. That's why it's advised for beta blockers, you start a very low dose in heart failure patient, and then you start titrating upwards.
Yeah. I think we can stop here. If there are any other questions, then we continue with ischemic heart disease, and with time we can even do myocardial infarction. Any other, or we stop here?
Hiral, what